what we're going to talk about today are behavioral and psychological symptoms of dementia. This is what they're called in the literature. It's BPSD. They are a group of heterogeneous, non-cognitive symptoms and behaviors that occur in the setting of dementia. So just to say a little bit about how they are so very heterogeneous. So we can have something that seems as simple as eating patterns, and patients can have pica, they can change their dietary preferences, they can have appetite loss, they can have hyperphagia. Irritability can be something like arguing, complaining, or impatient. So these are symptoms that have a wide variety of pathologies as well as clinical outcomes. You can go ahead to the next slide. Okay. Behavioral symptoms of dementia are as clinically relevant as cognitive symptoms for a few reasons. And this is because, for one, they occur in up to 90% of patients with dementia, so they are very, very common. They strongly correlate with the degree of functional and cognitive impairment, and individually they are independently associated with poor outcomes. So things like caregiver distress, they can lead to long-term hospitalization, the misuse of medication or polypharmacy, as well as increased healthcare costs. The pathophysiology for behavioral symptoms of dementia is unclear, but it includes a volume reduction and decreased metabolism in places in the brain like the prefrontal cortex, the anterior cingulate, the insula, and temporal lobes. There is neurotransmission imbalances in the cholinergic, serotonergic, dopaminergic, noradrenergic, and glutaminergic symptoms, and also can be influenced by premorbid psychiatric function. So things like neuroticism or PTSD are associated with more likely to have behavioral symptoms of dementia. Go on to the next slide. So what you're going to see clinically is this is going to be the person that comes, or their family brings them into your office, or you have a consult for somebody, and the question is going to be, the patient's agitated. Next slide. But what this really means is this is the heterogeneous aspect of behavioral symptoms dementia. It can be any one of these things. It can be somebody who's crying more than they usually do. They can be impulsive. They could be angry. They could be doing things like pacing or wandering. That also can be interpreted by people as aggression or agitation. You can go on. So when we evaluate symptoms of behavioral symptoms of dementia, so the first thing that I am going to do is interview and examine the patient. And I always like to give people the dignity, no matter how old they are. If they are my patient, I interview them first. Next, I'm going to interview caregivers and be specific with them. So when I'm asking about behavioral symptoms of dementia, I'm asking about what behaviors the patient's doing, how often they're doing it, and how severe they're doing it. Next, you need to consider your differential, especially with behaviors that are acute in onset. So with things that are acute in onset, I'm not thinking of a behavioral symptom of dementia, I'm thinking of a delirium. So this is when I would get something like a CBC, a CMP, I'm looking at liver function, a UA, thyroid studies, a urine drug screen, or perhaps a head CT. There are many scales that are available for interview inspiration. So I did link a couple of them. And so there are a few hyperlinks in the presentation that have additional information, but there are many scales that are available if you want to get a sense of how to ask your patients about these symptoms or their families about these symptoms. They're really more helpful when I use them for making the initial diagnosis of dementia, because as a psychiatrist, people come to me for any kind of behavioral problem. They think, a bad behavior or somebody doing something they shouldn't be doing, they come to see a psychiatrist. So I tend to use some of these questions in more of a sense of like, is this a dementia, especially in an older person, someone over 50. And I'm not saying that's an older person. It might be in someone over 50. I'm starting to think of some of these more particular questions to see in my mind, is this from a psychiatric illness or is this from an evolving dementia? So if I had to choose a couple of scales to use, I would use the NPI-12 or the Behave-AD scales, keeping in mind these are qualitative scales, not diagnostic. So you will not add them up to get a certain number that will give a diagnosis of behavioral symptoms of dementia. They really go through something like agitation or psychosis and go through each line item, like something about paranoia, hallucinations, delusions, and those are all separated under symptoms of psychosis. So it can give you some ideas of how to ask things for patients. There is no gold standard for screening, evaluation, or monitoring of behavioral symptoms of dementia. So these are all things that are helpful to us for qualitative purposes, but not necessarily for anything other than that. Next slide, please. I'm going to first talk about briefly the non-pharmacologic management. Go ahead. So sometimes this may be all that is needed for minor behavioral symptoms of dementia. For all people, I think we are all familiar with this, but I did want to include it just in case. Orientation aids, so things like clocks, calendars, television, lights on during the day, off at night, and scheduling tucker out time. Just like children need some time to burn off some energy, a lot of times I will tell nursing staff and people who are still ambulatory, we need to schedule some time for them to be walking around the unit. And I like to give patients, give patients a purpose, whatever it is to them. I will try to find something on the unit that they are able to do and have some meaning with. Caregiver training, and I linked an article with a randomized controlled trial there about caregiver training. What caregiver training generally does is reframe behavioral symptoms of dementia as reactions to unmet needs, discomfort, or as attempts to communicate. So it teaches family members a way to create soothing environments and de-escalate behaviors before they change into something that is maybe less manageable at home. Non-pharmacologic management is not consistently effective, but there is little risk to some of these, as well as few adverse effects. So things like aromatherapy, bright light therapy, massage, reminiscing therapy, or music, or giving activities with simple tasks to perform. So these are things like busy boards or patients folding things or keeping their hands busy. These are exactly the kinds of things that have very little, there's little strong evidence, but there's little risk. So we do them anyway. Next slide. Now I'm going to talk a little bit about the pharmacologic management, which is most of the reason why I get called to see patients. You can go ahead. So general pharmacologic guidelines for patients that you're prescribing in. Use the lowest effective dose for the shortest amount of time. Patients with dementia are often physically frail, so they have old kidneys, they have old livers, they may have decreased lung function. So they may have things like renal disease, liver disease that affects how drugs metabolize in the body. Orthostasis, which is common in the medications that I prescribe, can be deadly in an older person. So this can cause someone to fall, and that can precipitate a decline, a very quick decline in function. As in all patients, but especially in the older adult, avoid polypharmacy. They're often taking many other medications. So when we add a little innocent, little antipsychotic, we may precipitate some interactions here. If extrapyramidal symptoms occur, so these are symptoms that can occur when prescribing antipsychotics, reduce the dosage or switch as opposed to starting an anticholinergic. In an adult, if somebody has EPS, if they have a tremor or something like that, we are quick to start something so that they can be able to tolerate the antipsychotic better, like benztropine. But in an older adult, those things can independently precipitate altered mental status. So we tend to try to avoid giving additional anticholinergics if at all possible. And lastly, reassess the risks and benefits of psychotropics on an ongoing basis. Next slide, please. The first thing to do with someone with behavioral symptoms of dementia is to consider treating pain empirically. So I looked up some data on this. Painful conditions are present in 50% of patients with dementia, but only 20 to 40% receive analgesics for these conditions versus 60 to 80% of similar patients without dementia. And so why is this? And it seems very reasonable as to why this would occur. There's underreporting by patients as well as under-recognition by the caregivers. In an 8-week randomized control trial that I linked, there were patients were started on routine pain medication. So they started with round-the-clock Tylenol, and then if that didn't work, they chose one of the next 3, which was low-dose morphine, buprenorphine, or pregabalin. After 8 weeks, the agitation was down by up to 17% without adverse effects. So this is something that I generally forget to do, is just start an empiric Tylenol for somebody. You could also consider medications like duloxetine, gabapentin, lidocaine, or gels, but you would want to avoid things like TCAs, muscle relaxants, or NSAIDs in an older person. Next slide, please. So the next thing is to treat major depressive disorder, MDD, empirically. And I say empirically because we do have some scales for this, but sometimes it does feel like a bit like I'm adding this empirically. So in terms of MDD, think of depression as having like maybe about 3 phenotypes. And so when we think of major depression in the typical way, we think of the adult. That's the adult who is depressed with the mnemonic SIGI caps. That's what we're looking for in adults. Children look differently from that. Children may not have the more anhedonic picture that adults have. They tend to be more irritable. They tend to be more clingy, things like that. So it can look a bit different in children and adolescents. And in older adults, especially older adults with dementia, it can also look quite different because we are generally looking for somebody with depression to be like a complaining person. Depression, is a little bit and a lot of psychiatric illnesses are in the eye of the beholder. They are the ones telling us that these particular emotions are overwhelming or getting in the way. With an older adult with dementia, we may not have that. So this is what we usually use for an older adult for later life depression. This is the geriatric depression scale. So with some of these questions, do you really think that an older person with dementia can answer some of these questions? So things like, do you often feel helpless? Are you basically satisfied with your life? These are complex questions that they may not be able to answer so well. Next slide, please. Some people have used the Cornell scale for depression in dementia. And so this is freely available, and I linked to it. These are all objective measures. So the person does not have to be able to say to you, I am depressed, I feel sad, I feel hopeless all the time. They don't need to say that to you. These are all objective measures. And I particularly like how they include behavioral disturbance in this. So you can see things like restlessness, hand wringing, hair pulling, and it asks the rater to evaluate those. So I think this is a more helpful measure for depression than the GDS in older adults with dementia. Next slide, please. So when treating major depression in the older person, SSRIs are generally the mainstay, but others are more commonly used as well. So things like escitalopram, sertraline, and citalopram are the more common ones. Citalopram does have a warning with QTC, but this is mostly disproven at this time, but still it's something to be aware of and to discuss with your patients and their families, that there is this black warning about a heart issue. With SSRIs, they have a risk for hyponatremia in the elderly, so I generally check a BMP about 2 weeks after the initiation. There is a mildly elevated but still present risk of bleeding, and especially when this is combined with warfarin. So the antidepressants with an elevated risk when combined with warfarin are citalopram, fluoxetine, and paroxetine. And then I included mirtazapine and amitriptyline. They have an elevated risk when prescribed of bleeding when prescribed with warfarin, but these are not SSRIs. And then no significantly elevated risk with venlafaxine, sertraline, or escitalopram. Now, we might not want to prescribe venlafaxine in an older person because of the risk of hypertension, but this is certainly with warfarin, it should spark some thought of what is the risk of prescribing this? Do I want to prescribe something else? How badly do I need a med for depression? In terms of the bleed risk with the SSRI itself, not when it's combined with something, there are a few situations in which I would pause in prescribing the SSRI. This would be with an active head or GI bleed. So yes, active head or GI bleed. 3 months post intracerebral hemorrhage. With warfarin, I would consider holding it. With active peptic ulcer disease, if there is a high-risk surgery, so most surgeries that patients undergo are not high risk for bleeds, but this would be something to ask the surgeon if they are particularly concerned about an elevated risk of bleeding with a surgery that your patient's having. always when the risk of bleeding is greater than the risk of relapse of depression. And then finally, platelets under 20,000. So these are patients who a lot of times have cancer who have low platelets. Under 20,000, I would consider holding the SSRI. You can go on. For antipsychotics, so antipsychotics are for use when non-pharmacologic or treating depression and or pain does not work. So we need to talk about the black box warning in older adults with dementia. It exists, it definitely does. So I looked up what the actual numbers were. The risk of death with an antipsychotic was 3.5% versus 2.3% without it. And this was mainly due to cerebral vascular disease and infections. However, it is still the mainstay of treatment for agitation and aggression in dementia. So certain medications that we use include aripiprazole, risperidone, olanzapine, quetiapine, brexpiprazole, all second generation or third generation, if you want to call aripiprazole that, second generation antipsychotics. I tend to use some antipsychotics in sort of special circumstances. So these would be things like haloperidol, clozapine, or pimavanserin, and we'll talk about those. Next slide, please. Okay, haloperidol. Please have a healthy relationship with haloperidol. I don't want anybody to be scared of haloperidol. I think we tend to, as clinicians, we tend to be very scared of haloperidol, but I want to at least challenge some of those preconceived notions about it. Haloperidol has no anticholinergic properties. There is little risk of hypotension or orthostasis, and that is what I am looking for an older person. If I'm using this, so I'm using this as a PRN mainly. I'm not doing any standing haloperidol. I am doing, or scheduled haloperidol. I'm doing PRN haloperidol. Haloperidol is okay with bad kidneys, bad livers, and does not suppress a respiratory drive. So if I give a whole bunch of haloperidol, I'm not worried about me, the psychiatrist, having to intubate someone, and that's not a good idea if I'm having to intubate someone. It can be given any which way. It can be given IM, PO, IV. The onset with IV is 30, or IM and IV is 30 minutes, and the duration is about 12 to 24 hours. Extrapyramidal side effects can occur, so things like a dystonic reaction, akathisia, or Parkinsonism, and that's more likely with IM and PO, not so much with intravenous. QTC prolongation is rare at low doses, and so one of my favorite facts or trivia facts about haloperidol is what is considered low dose. And under 20 milligrams and under, total daily dose is considered low dose, and this is like, people get scared, prescribing 2 milligrams of Haldol once. So low dose is under 20 milligrams a day. It can also lower the seizure threshold. Most cases, you do not need to get an EKG daily, but everyone is scared of it, so it gets stopped anyway, which is appropriate for it to be stopped. So when I'm using an antipsychotic, a lot of times, I'm hoping that in 2 weeks or so, 4 weeks, that this medication is stopped. Things like quetiapine, olanzapine tend to just stick around on patients' medication lists because we're not as scared of them, and they tend to stick around. But haloperidol, they tend to get stopped, and most of the time they're stopped appropriately. So this is another reason why I am not scared of using it, especially in the hospital. You move ahead. Speaking of some of the specific antipsychotics that I use additionally or instead of, so quetiapine, I tend to start as 25 milligrams twice daily. You can start at 12.5 milligrams twice daily, and you can even go as low as 6.25 milligrams as an outpatient. They do not generally allow that in the hospital because it's a quarter of a pill, and they can't, and pharmacy can't, standardize how much that is. But as an outpatient, if someone is quite sensitive to the sedating or orthostatic effects of quetiapine, you can use little whiffs of it. So it is a dopamine blocker, but it rapidly dissociates from the receptor. So neurology tends to prescribe this for patients with Parkinson's disease. The main side effects of quetiapine or orthostasis. When we use quetiapine for delirium, we generally vastly underdose the quetiapine. It takes a while for us to get up to a solid dose of quetiapine that I can use for delirium. So I don't generally use it all that much for delirium. I'm thinking for delirium like 200 TID. Like I'm trying to get to a 600 milligram total daily dose of this medication. It's really only good as a scheduled medication. The onset of action with an oral dose of quetiapine, and I think I say it somewhere later in the presentation, but it's hours, and so it's not good as a PRN medication. Olanzapine has this oddly long and variable half-life, especially with older people. It is hepatically metabolized, so older livers tend to take a very long time to metabolize olanzapine. It's something like 24 to 54 hours. It can be a long time, and people can be asleep for a very long time when you give olanzapine. Droperidol is generally not a good idea for anybody with any hints of dopamine problems. Droperidol is a very, very potent dopamine blocker, and so it is very helpful in an adult with undifferentiated agitation because it works very quickly when given intramuscularly. But with older adults, especially with hints of dementia with Lewy bodies, if you're thinking about that, or Parkinson's disease, this can be so dopamine blocking, it can paralyze them. So that's not what we want either. You can go ahead. Other medications that I tend to use in a less, I guess, like there isn't as much evidence for these meds. So things like prazosin or clonidine, they are generally helpful. There are a few side effects, but especially if you're giving a second generation antipsychotic that can cause orthostasis, you need to be watching out for their blood pressure. Things that have been shown to be ineffective at particularly the behavioral symptoms of dementia, not talking about other symptoms, but things like memantine, donepezil, valproic acid, and benzodiazepines. So valproic acid tends to be prescribed more often these days because it's simply just the non-antipsychotic option that people tend to still remember, but there's just no good evidence for it. Ginkgo biloba, 240 milligrams a day has shown some benefit in low to moderate quality studies. So in patients and families that are looking for something more alternative, ginkgo biloba. Cannabinoids, there have not been any studies that have shown good effects with it consistently. There are some that are like a one-off that show some, but nothing on a larger scale. Melatonin can be helpful with sundowning, but remember to dose this with dinner. So there are some people, including myself, that if I take melatonin at nighttime, I will go right to sleep, which is why I try not to take that often, actually. But how it's generally supposed to be used is a few hours before going to sleep. So with older people, I tend to have them take it with dinner if it's not working when they take it at nighttime. Move ahead. Okay, so I'm going to talk a little bit about treatment algorithms. All of these were based on the article that I linked from Harvard South Shore. Go ahead. So let's start with the emergent behavior, the emergent situation. So this is something like when you are about to call the behavioral code in the hospital. Olanzapine generally is used first at teeny tiny little doses, so 1.25 milligrams up to three times a day. As I mentioned already, it's not a great long-term medication due to the odd half-life, so a lot of times I tend to not use this one. I tend to use haloperidol at low doses. It has the fewest side effects for a parenteral medication, so this is generally why I use it. You can consider something like a very tiny dose of lorazepam, like 0.5 milligrams up to 2 milligrams a day, but I would really only use this for a patient with dementia with Lewy bodies or Parkinson's disease where I really don't want to give a dopamine blocker. You could consider an extra dose of a daily medication depending on the medication, time to onset, and whether it's available parenterally. So if somebody is taking olanzapine as a regular medication, you might use another dose of that in a parenteral formulation. So new, hot off the press. So sublingual dexmedetomidine is IGALMI, and it has some evidence for use with the older population. It comes in like a Listerine strip sublingual formulation. So I have tried a placebo version of it. So like once you get it onto the mucosa, it's not coming off. And this is quite expensive. So I don't remember exactly how much it is a pop, but it's quite expensive. So I don't expect hospitals to be stocking too much of this, but this might be something to consider especially in an inpatient setting where you might want to use something a little bit less, where you might not want to use an antipsychotic. What else to talk about in GOMI? You do have to get close to the patient. So you do have to be able to put it in their mouth, or they have to be able to put it in their mouth themselves. So that is something else that may be of note. You can go ahead. So urgent. So when we're thinking about urgent behavioral symptoms of dementia, this is something in which, like, when I think about it, I think of this is somebody that is in the hospital to treat the behavioral symptoms. So with this first block here, so if not recently on a D2 receptor blockade, try aripiprazole. So why are we saying this? So aripiprazole is a partial agonist at the D2 receptor. So if somebody has been on a D2 blocker for some time, for like weeks, if giving aripiprazole, you could precipitate some additional agitation because it will yank the dopamine blocker off the receptor, just like a buprenorphine might. More of the literature, especially in adults when switching antipsychotics, tends to say that this isn't something that's seen quite often, but you would keep it in mind. Aripiprazole is generally tried first. It's equally efficacious as risperidone, but with fewer side effects. I go up to a max dose of 15 milligrams for aripiprazole. Sometimes I've gone a little bit higher, but generally the max is 15. Then I would try a risperidone at tiny, tiny baby doses, and then could try prazosin up to about 2 milligrams in the morning and 4 milligrams HS. Consider the timing with these medications. So if you want the medication to kick in at night, you've got to give it early. So i.e. dinner. So these are not medications that are going to cause sedation right away. So quetiapine oral takes 3 to 4 hours to kick in. So if you want to give it at HS, they are not going to start feeling that sedation until, if it's HS and it's like 8 o'clock, it's going to be midnight before they start feeling a little sleepy. So maybe give it at dinner time. You can go ahead. So non-emergent. So these are the outpatients that come to see you. So first, as always, decrease the anticholinergic load. Oh, yes. Okay. So Rexulti, let's see. What was the question? Comparable alternative and way to cross titrate someone, patient. Yeah. So Rexpiprazole is fancy aripiprazole. So I would just use aripiprazole. If they haven't tried aripiprazole yet, I would use that because it's, oh gosh, I believe it is, gosh, I don't remember if it's like, so paliperidone is a metabolite of risperidone, but I don't remember if aripiprazole is the parent drug of brexpiprazole. I don't quite remember which one it is, but if I had to choose something else other than brexpiprazole, it would be aripiprazole. Those two are related. So yes, so sleep optimization, consider trazodone. You're welcome, Matt. So consider trazodone for sleep optimization. After 200 milligrams, I'm not sure what effect trazodone is having, but 25 milligrams up to about 200 milligrams. Initiate the memory enhancer, so donepezil and memantine, 5 milligrams up to a max of 23, and for memantine, 5 milligrams daily up to a max of 20. With these medications, they may cause hallucination, so especially memantine. So I keep this in mind, especially if I am treating frank hallucination in someone, that may not be the time to start the memantine. So this is where we get into treating and kind of empirically treating a depression. This is the escitalopram and sertraline. So a max for 10 milligrams daily of escitalopram, I will go up higher than that. And then up to the max of 20 generally, and then for sertraline, a max of 200, which is generally about the same for adults. Second generations antipsychotics and prazosin, as we've previously talked about, and note again, there's no valproic acid in this algorithm, so there just isn't such great evidence for it. The thing to keep in mind with this is if patients are presenting acutely, make sure these medications are started. Absolutely sure you're going to be you're going to be using an antipsychotic acutely or emergently. But if they're not on an antidepressant, that's the time to start it. So that's something usually what I will do. Next slide, please. Okay, so some special considerations, special cases. Okay, with Parkinson's disease, so Parkinson's disease, dementia with Lewy bodies, two sides of the same coin here. Parkinson's disease has late psychotic symptoms, so you generally see the hallucinations and the psychosis towards the end of the disease. And dementia with Lewy bodies, you tend to see early psychotic symptoms. And this is key with sensitivity to the side effects of antipsychotics, especially olanzapine. And I'm not sure why olanzapine in particular, but if you are treating somebody with dementia with Lewy bodies, I would stay away from the more potent antipsychotics. Frontotemporal dementia also bears some mentioning here. So there are personality changes, disinhibition, apathy, changes in eatings like hyperphagia. All of these symptoms may precede the cognitive decline by several years. So as a psychiatrist, sometimes I will see patients who come in with this new onset of personality changes. And so that's sometimes what I'm thinking about is this a frontal dementia? Huntington's disease, there are all common psychiatric symptoms that occur with Huntington's. Depression, suicidality is common, obsessions, compulsions, and irritability with late signs of psychosis. Next slide, please. So I do want to call out psychosis in Parkinson's disease and dementia with Lewy bodies. So why is this challenging? I had mentioned it briefly. So these are all diseases in which dopamine is particularly low for some reason. All of our medications for agitation tend to deal with dopamine. So the FDA approval, there is FDA approval for pimavanserin. However, there is not. A lot of insurances will not cover the pimavanserin. That's all I will say. And certainly we don't stock it in the hospital. In a lot of these patients, I consider what I have called rational polypharmacy. It's not me. It's something that I didn't come up with it. But rational polypharmacy. So the combination of clozapine plus aripiprazole, or aripiprazole plus another antipsychotic, but the clozapine plus aripiprazole has some good evidence and some good safety data with it. So this would be something to consider as well. Quetiapine, despite being used frequently in this population, and it's because it binds weakly to the dopamine receptor, has little widespread evidence for efficacy for it. So I think we go to quetiapine very often with these patients, but there's not a whole lot of efficacy with it. Do not give droperidol to this population ever. These are patients with dopamine problems, so potent dopamine blockers can cause movement paralysis. And then I would avoid olanzapine as well, because that can precipitate some frank EPS with these patients. Next slide, please. So these are the delirium on dementia patients. So what does this mean? So this is the person with dementia who becomes delirious or encephalopathic. This is what we're looking for with acute behavioral changes. When you're managing this, don't stop at the baseline antipsychotic unless it's clinically indicated for some reason. So it's this, I think of it the same as I would for pain medications when someone's having an acute pain issue. You keep the baseline and then you add to that. So you can add a PRN medication. I usually use haloperidol or olanzapine. You can increase the baseline scheduled antipsychotic or add another dose to it. So if somebody's getting a daily dose of a medication, you can add a twice daily medication. But remember to stop the PRN or taper down to the baseline dose when the delirium resolves. That's key. Next slide, please. So catatonic features. So some patients with dementia have movement abnormalities that look a bit like catatonia. So what do I mean with catatonia? That is a very psychiatry term. So I included this picture of this guy walking because people a lot of times tend to look very stuck walking, like they'll get stuck mid gait and they can't quite move forward. They may do odd things repetitively. Sometimes the odd thing is a typical thing for somebody to do. They just do it more often, or it's a kind of a weird movement. And these are patients where it's not better explained by a Parkinson's disease or dementia with Lewy bodies, where you would expect there to be some movement difficulty. With these patients, I consider a small dose of a benzodiazepine, like baby dose, so like 0.25 milligrams of lorazepam twice daily, to see if that can help with some of that movement difficulty. Next slide, please. So older people with primary psychotic disorder. So these are older people with schizophrenia or schizoaffective disorder. Dementia is the natural course of, or is the natural ending to schizophrenia or primary psychotic disorder. Initially, this was described, and when it was described, it was initially called dementia precox. But we are not totally sure why exactly this happens. It can, some people will say that the side effects of the medications that we prescribe, so things like antipsychotics have metabolic side effects, and then we create a vascular dementia in these patients. Or is it because of poor self-care that can lead to lack of medical care that ends in a vascular looking dementia? So in this population specifically, if not done already, ask psychiatry to consider starting a long-acting injectable antipsychotic if they're taking it, which can assist as the patient may be less willing to take medications by mouth. So these may be especially helpful in older patients who have a long-term psychiatric illness. Next slide, please. Okay, so apathy. I believe this is the last slide that I have. We don't have great treatments for apathy. The evidence that I could find had a low-dose stimulant. So methylphenidate can improve apathy, cognition, and function. So these are things that you generally see in more of a frontal dementia, but these can be seen in other forms of dementia as well. Start 2.5 to 5 milligrams twice daily and increase by 2.5 to 5 every week. There is no evidence for efficacy for apathy in things like cholinesterase inhibitors, memantine, or antidepressants. Next slide. Oh, okay, yes. Okay, so we got to talk about antipsychotics in nursing homes. So nursing homes don't like to see antipsychotics, especially haloperidol, despite their evidence for efficacy and safety. Because nursing homes a lot of times will decline to take patients that are on antipsychotics, patients end up on regimens that don't make any sense clinically. So they end up on benzodiazepines or higher doses of benzodiazepines. They end up on valproic acid, which has its own set of side effects, or in restraints. And that's just not clinically appropriate. I would much rather have somebody on an antipsychotic and up and mobile and walking around rather than on other medications that don't make sense. What they are looking for, so I have read the regulations, so you don't have to. You need to show documentation in your note about why the agent was chosen and whether tapering will or will not be done at the present time. So the easy ones, medications for primary psychotic disorders or bipolar disorder should not be tapered unless there are mitigating circumstances to that. But otherwise, tapering an antipsychotic given for a behavioral symptom of dementia, we can do a slow taper and see how the patient does with that. If they have a resurgence of symptoms, then it gets increased again. But this is really what the regulations look for, is a decision of whether or not to taper. And we do need to document our decision, our clinical decision on this.